Welcome to Health Talk. I'm Dr. Morgan. I'm a family nurse practitioner, and today I'll be talking to my dear friend, Nancy Fong. Nancy is a nurse practitioner. She's on the OBGYN side of things, and she's very experienced in this area. And today we're going to be talking about women's health. I've been waiting on Nancy for quite some time to share her expertise with me on the Health Talk. And we're going to talk about some issues, some elephant in the room, some unpopular topics that people don't want to talk about. Some of them involve moral, spiritual belief, but we have to address women's health and women's rights in these discussions. Welcome, Nancy. Can you tell us about yourself?
So, Nancy Fong. Cheryl and I met in NP school. It was about 9 years ago. Yeah. Time flies. And I've been a nurse for about 20 years, roughly. I've done surgical trauma. I've done telemetry. I've done a lot of things, but my specialty is high risk OB before I became a nurse practitioner. So, and it's the best job I've ever had. So mostly, I guess it was destined for me to end up in women's health because it's something that I have a passion for. So I am currently OBGYN nurse practitioner, and that's what I've been doing for the last 8 years.
Yes, Nancy, I remember when I asked you, what do you do back in NP school? And you said, I deliver everything that comes off 9 to 5 or comes off the road. So all the women who got pregnant, no prenatal care, drug addict, everybody, placenta, placenta abruption, everything. Mm-hmm. And I remember when you got your first NP job and that was supposed to be in OBGYN and you said, no. I want to do primary care. And I said, Nancy, no.
That's not for you.
You are an OBGYN nurse practitioner. You went right there and you stayed in that field because that was you. That was 100% you.
I do believe that when you do something that you love, you really don't work a day in your life and I say it all the time when people look at me like I have like 5 heads or something, but I absolutely have a passion for what I do. And not only that, I have a passion for what I do, but in a certain area. So I practice right now in Belle Glades, Florida. And if anybody knows that area, it is a very poor and underserved area. And people are just very grateful for you to help. And when they come in and they can talk to you and you make them feel like not just a number, but a person, and they're very grateful for that. And for that, I am very happy. I feel like I am living out my purpose.
Exactly.
And before we get into that, Cheryl, I don't know if I told you that I'm trying to open a clinic in Montego Bay. Oh. I am very, very close to doing that. I'm very, very close to opening the door, actually. I was in Jamaica this past weekend. I had shipped some things down, some beds and furniture stuff and equipment and colposcopy machine and stuff like that. That was donated to me. So most of it was donated to me by an OBGYN up here who was going out of, she was retiring. And God was so good that somebody called me and told me she was retiring. And when I went there to buy some stuff, she told me I could take whatever I needed.
Wow.
And that's when I know that I was on the right track. I knew that God had a purpose in life for me, and I was doing exactly what I was supposed to be doing. So I'm hoping that in about another month or so, everything will be up and running. And this thing with me opening this business in Jamaica came from my aunt who we grew up together. She was 47 years old. May her soul rest in peace. She passed away last year of being 90 days after diagnosed with stage 4 cervical cancer in Jamaica. Now, this is someone who has always been going to the hospital and the clinic, to doctors for heavy menstrual period. And, they've always, and, she's very anemic because of that. And they are, it's premenopause. And I guess somebody decided to do a check. And when they did the check, she had stage 4 cervical cancer. Now she ended up hemorrhaging. She has a clotting disorder where she got DVTs. And she had a pulmonary emboli. They cannot treat that because you cannot give blood thinners when somebody's hemorrhaging and the H&H is at a 4. So what happened? She ended up with a stroke. So she had a stroke first within about 30 days of her diagnosis. Then she get a second stroke and she was dead in 90 days. So she had three things against her. One was the cancer, which would have taken the longest, but the hemorrhaging and the anemia was very close to taking her out. And then the blood clot, that can be immediate as well. So that's where, and I feel like it's a lot of disparities and the reason that in Jamaica, not as it is here, but in Jamaica, I feel like there's not enough care for us, especially for women and education, because I did ask her if she got pap smear done and she told me, yes, she got it done and they told her everything was okay. And this was like 2 years ago. There's no way you're going to die from stage 4 cervical cancer 2 years later. It takes at least 3 to 4 years to turn into cancer from the
What I can tell you, Nancy, is that the public system in Jamaica, when you do certain tests, I did an interview with Jesse James. He's a counselor for the People's National Party. When you do certain tests in Jamaica, it can take months, maybe years to get back your result.
Oh, I'm quite aware
of privately, then you're not going to get anything. So I hope that your clinic will really reach the people who need it. And I want you to come back when you're open so we can talk about it, like to promote it and get the word out so people can know how to find you and how it's funded and, pricing and all of those things. And that's really a good move that you are doing. So today we're going to be talking about maternal mortality rate in the US, and it's not a US problem, it's a Jamaica problem as well. But before we even reach into the maternal mortality rate, it starts from childhood. It starts from when these kids go into puberty. What are we doing in terms of preparing these kids for, in terms of sex education to prevent pregnancy? Because I believe that how they're prepared, they will take this information into adulthood to be more responsible in terms of their sexual health and making decisions and protecting themselves as, young females. How should parents prepare children, especially females, to be responsible in relation to their sexual health, pregnancy prevention, and to take this information into adulthood? What would you tell a mother with a 13-year-old or a 10-year-old girl going into puberty?
You have to have the talk. And when you have the talk, you cannot be shy about telling them exactly what to expect when they go out there, because, the predators out there, and I call them predators, and some of them are not predators, but they're out there and they're not going to give them the talk. And as parents, we have to make sure that our daughters and even the boys are aware of the diseases that are out there. Pregnancy is, like, to me right now, pregnancy is one of the least harmful thing in terms of what you can get if you're not well educated, as far as STDs like HIV. You can get herpes, you can get things that can last forever, and you can get into sex trafficking. So you have to really talk to your children about the dangers out there. Educate them, let them know, show them pictures. Those are pictures. I tell you, a picture can go 1,000 more than you just telling them. But when they see it, they'll think twice before they make certain decisions, and going out there. I feel like with the mortality rate, for one, it's a lack of education. And I do think that if you look at the statistics, it's very high amongst Black women.
Yes.
One of the reasons for that is we're Black people. They don't listen to us. And it is a very sad situation. And when being an OBGYN and a high-risk maternity nurse for so many years, I've been there. I've been on the forefront. And even myself as a nurse in the same facility that I worked, when I had my last child, I was crying out for help. And I don't think they intentionally didn't want to help, but I also think that the workload for the nurses were so much that they just figured, oh, she's okay. But my bladder was so extended, I could have easily hemorrhaged you know. But because I have the knowledge that something wasn't right, I had to call somebody specific and say, look, this is what I need you to do for me. And when they came and they did what they had to do, it could have been a different outcome. So in general, Black women, Black people don't get the same treatment as the other races.
Especially when it comes on to pain, they don't believe that we are in pain. I remember when I had my last child and I was having UTI symptoms after delivery. And even though I was telling the nurse, like, I'm having this problem, and she called the doctor, they did a urinalysis. I said, oh, it's normal, but I'm having these symptoms still. And I had to be begging and begging. And I remember a friend of mine who's a doctor, she came to visit me and she shook her head and she said, unfortunately, Black patients are not listened to. And they're not given the same attention to, as a white
Concert
because, they just don't believe what you're having is real.
is
And it
real.
took like 2-3 days before I was able to go on some antibiotic. And I had to stay with that discomfort all this time. And I also am a healthcare professional. So we are saying that we need to prepare our young girls, about, pregnancy, more about STD, because pregnancy, baby's going to come and you will enjoy your baby, but you're not going to enjoy
and it might even make you, and I say that because I was one of those teenagers who had a daughter at 16. My daughter is 30 years old now, and I cannot imagine my life. She was my motivation,
Yes.
to be where I'm at today. So I counsel my young girls on that when they come in. In Belgrade, you see a lot of teenage pregnancy. And as a matter of fact, these young girls over there, it seems as if they all want to have babies. They even come in there trying to have babies,
Oh,
and I'm
really?
like, look, you're 18. Why are you trying to have a baby? Have you finished school? What are your plans for life? Because there's nobody over there to talk to them about these things.
Exactly.
So I sit and I have discussion with them. And then when the 18 or the 15-year-old or the 13-year-old come in pregnant, I also sit and talk to them. And I'm like, look, don't make this be the end of the road for you. Use this as a motivation to go forward, because this baby depends on you. And it's a great pleasure of mine to sit down and talk to these young girls, because when they leave, they come back and they're so happy because they feel like a person, they feel like someone here. And sometimes it's not that their parents don't want to talk to them, but there's so many things going on in the poor parents' life too sometimes, that they just brush it off. And you don't realize that the days are going, the months are going, and the children are growing older, and they're developing and forming their own perception of life. And next thing you know, they think, oh, having a child is the way to go, or having a child would make the man want to stay, or any of these things.
Yes.
So you can't always blame the parent that they don't do it, because sometimes they don't have the tools themselves either to do it. So when you get a chance to do it, you have to do it as a healthcare professional.
And sometimes because the topic is very sensitive and not every parent know how to bring that information to their children. So they prefer just not discuss it, and they will learn eventually.
And then they learn it from the wrong place.
Exactly. We're moving on to talking about contraception. So as a nurse practitioner, my first encounter with a mother brought in her 13-year-old daughter for her to go on contraception, and I just could not prescribe it for her. It didn't seem right to me, right, to put a 13-year-old girl on contraception, and I eventually never prescribed it. I spoke to mom and educated her about sex education, educated the girl, but as I worked as a nurse practitioner in the field more, I realized that a lot of Americans put their kids on contraception at a very early age. So you are an OBGYN nurse practitioner. What is your take on this? What options are out there for young kids in terms of contraception, and even older female? What side effects and risks and complications that come with it, especially when you go on it too early?
Well, 13-year-old is very, very young. But when you're in the office and you see a 13-year-old coming pregnant too, you wonder which risk, you you weigh the risk, right, against the benefit. And if there's a 13-year-old who, you know, is very defiant, and it's a 13-year-old who doesn't want to listen to her parents or whatever, then you might have to give that 13-year-old some contraception just to prevent the pregnancy. However, you still have to give them a lot of education as far as it's concerned with STDs and all of the dangers that are out there. Because at 13-year-old, you're out there, you're I'm sorry, my camera is falling apart. You don't know the dangers of that awaits you out there. So you really have to educate these kids. And I think the mother is just doing the best that they can, you know, by trying to provide contraception for these kids. Now there are side effects to that. You know, DVT is a big one. All hormonal contraceptions have issues with DVT, and it is very, very common. The other thing too is they like to put the younger girls on Depo-Provera, which is the injection that you get every 3 months, because they don't have to remember to take a pill. They just come in and get an injection, and it's easy. A lot of times they don't get a period with it, and it's also they like that. However, you can have bone loss with that. That's one of the main problems with the Depo-Provera, is that you can develop bone loss with all the other complications. There's a list of complication that can come from that, but the bone loss is the major one. So I would usually have, you know, people on those on Depo way up in their 20s, but after that I try to tell them to try something else. Their Nexplanon that you can put in the arm, it's a sub-Q, it's a little catheter that you put underneath the skin that lasts up to 3 years. You don't have to come back and do anything. 3 years, you come, you take it out, you replace it if you want, or you change to something else. They have a lot of different IUD options that last for different lengths of time. You have the Kyleena, the Mirena, and the Kyleena is 6 years, the Mirena is 4 years. I think they just upped it to 5 years. And then you have a non-hormonal option, which is the Paragard, and the Paragard lasts up to 10 years. A lot of the older people, and when I say older, in their mid-30s on 40s, they usually put the Paragard in, because there's no risk of a DVT with the Paragard because it's non-hormonal.
Okay, so that is good. So when we talk about contraception, we're pretty much focusing on female, and I realize that the world think that contraception is a female thing, it's a female responsibility, and it should not be a female responsibility. And what option is out there for male?
Well, it is not only a female responsibility, and I have to tell you, within my last 5 years, I'm seeing more and more male going for the vasectomy. It is also a service that is provided free of cost through the health department. So, and every year the health department get a certain amount of funding for vasectomies, and most of the year they don't even use half of that funding because most men don't want to use it. There is a stigma to say that if you do vasectomy, your PP won't work anymore, and men feel like they are a lot of men feel like they're taking away their manhood, right?
Yeah.
And you also have to educate them and say, look, no, the same place where the sperms come from is not the same place where give you an erection. It doesn't work that way. So you have to educate them too. I know for Jamaican man, they don't want to hear nobody going nowhere near there. Most of them. But there are, of course, the condom, and then they have the vasectomy, which is very effective.
I think there's a new one that has been released recently. I don't remember if it's a gel or something like that, but can you imagine like a contraceptive pill for men that they should take every day?
Take it anyway. Believe me, they don't even want to take blood pressure medication, let alone and that would just their manhood. But there are some spermicide that you can use during sex to decrease, but those things aren't very effective. You know, maybe a 90%, because even taking the pill the way it's supposed to, the effectiveness is about a 95%. So
okay,
People even get pregnant on the IUDs, it is not very common. Like I say, effectiveness is about 90-95%, but it is still possible. So for you to just put a gel on, you may not put enough on. And who wants extra gel if you don't need gel?
Definitely. So let's go now into the meat of the matter. We're getting closer to the elephant in the room. Many women have used abortion as a means of contraception. What are the risks and complications of this? And I didn't know that so many women use abortion as contraception until the abortion ban came around.
Absolutely, they do. Now, is a thin line with this abortion thing. Now, I believe that every woman should have the right to choose. I do believe that, because there's some circumstances that you wouldn't want to carry a child in the world. It's not fair for the child, and it's not fair for the mother either. And I believe that every woman, it's your body. You should have the right to determine what you want to do with your body. However, saying that there are early abortions and then there are late-term abortions. Late-term abortion, I believe, should only happen if it affects the life of the mother or the life of the fetus. Like for example, there's a condition that the fetus have that is non-compatible to life. That is okay, because I believe that's a cause for abortion, because the fetus die inside of the uterus. In those cases, I think it is important. The other thing is, if for the mother to, if her life is at risk in any form, I feel like that's one of the only way that late-term abortion should be performed. Otherwise, I believe that up to 8 weeks for me, I think, would be acceptable. But everybody have a different opinion of what they want to do. So people do use it as a terms of contraception, and I think it's wrong. I think it's terrible to do that. I think that should be a last resort. You know what I'm saying? Yes. If you're going to anywhere past 8 weeks, because by 8 weeks you find out you're pregnant, you must be able to determine what you're going to do. You know what I'm saying?
Exactly.
Right? Now, even though there's a heartbeat from about 6 weeks, it's still a heartbeat. It's not a life. Now, let me not say not a life, but I feel like early term pregnancy, the risk is still very great for you to lose that pregnancy up to 12 weeks anyway. The risk is very high. So, but having termination 15, 16 weeks, 4 months and all that kind of stuff, I don't believe in that kind of stuff, and I'd never support that. Now, you can still have an abortion in Florida, but up to 15 weeks. You have to have a 24-hour turnaround window before your first consultation with the doctor. That's to make sure that that's what you want to do. It's kind of like getting a marriage license. You have to wait 3 years you can use it. And I think those are good things to put in place, because you might go home and decide, maybe I don't want to do this. Maybe God want this to happen, or whatever the case may be. But I do think that is that's good. But you can still get an abortion in Florida.
In Texas, it's like a zero tolerance to abortion. Even I know somebody who had a miscarriage recently, and they didn't even want to remove that.
Well, that's where the law. I have a problem with the law, because if you have retained product, that can cause problems for the mother. She can die. She can hemorrhage, she can lose her uterus and lose the chance of having other children. So the law needs to really clearly state when and how an abortion can be performed.
Yes.
And that shouldn't even be, because if there is no life, then it's not an abortion.
Exactly.
If there is
the mother's life is at risk at that point.
DNC, it's just a simple DNC. That's what it is. So I do believe that they need to make the law more clearer.
So right now, there are a lot of legislation to protect the fetus in terms of the abortion ban, especially in some states like Texas, where I live. And they talk about a life is a life, but there's nothing done. There's not much emphasis on protecting women in prenatal care and in taking care of the baby after the baby is born. So they just want to know that this life comes into this world, but they're not taking care of the mother. And there's a lot of women who die during childbirth. So in terms of the maternal death rate, what are some of the circumstances that would have placed a woman in a position that she need to have abortion? We know we talk about miscarriage. What are some of the other reasons why you think a woman would come forward and say, okay, I didn't have a miscarriage, but I just don't want this child?
There are other comorbidities that a person could be having that would put their life at risk. A person with a lupus, person with cancer, a person with diabetes, hypertension, all of those put a woman at risk for a complication during pregnancy, both for her and the fetus. So if for example, she has an uncontrolled diabetes or kidney issues or other, comorbidities that would have prevented her from carry a child safely, then I think that the risk should outweigh, the benefit should outweigh the risk here in this case. You should look at
most of the time when you hear this conversation, what is put forward is, why didn't she do something to prevent the pregnancy instead of waiting for the pregnancy to happen?
The problem with that, the same people who are putting a ban on abortion, they're the same people who do not want you to have contraceptions. They don't pay for it. So what are you supposed to do? Just not have sex?
Exactly. Because I know that some insurance don't want to pay for contraception.
Correct. And it's very expensive. So you don't want to pay for the contraception and you don't want the person to have an abortion. So if something happened and they become pregnant,
and then there's not a lot of emphasis to place on maternal health and making sure that these women deliver babies safely, carry a safe pregnancy, and deliver these babies. So where do they draw the line in terms of women's health? Because I think women's health really, really get a bad hit.
It does. There are things in place for pregnancies. For example, in the state of Florida, they do have programs for pregnant women. Whether you're documented, undocumented, you are able to get the care you need during your prenatal period and delivery. So they covers that in the state of Florida. That I know for sure. So there are a lot of programs here that support women in that case. But a lot of the mortality rate in women is mainly black females that have a higher mortality rate than any other race. And that is just because we're not being heard. They don't believe us when we say we're in pain. In 2015, just before I had my last child, I had a patient who came in and she had a C-section and she was complaining of a lot of pain, and I don't think her pain was really taken care of, or they didn't investigate why she was having that much pain, and next thing you know, she was hemorrhaging inside and she died. Serena Williams is another example. She is right here in West Palm Beach. She's a celebrity, but she's still Black, Yes. And she also has had a history of a DVT, so she knows what it feels like. She knows her body. She's an athlete, so the top of the top when it comes to athletes. So, and she complained to them, and they didn't listen to her either. She was adamant about her condition, and that's the reason why she probably survived a blood clot, because she did have a blood clot. So the one of the reasons is just that we are just not being heard. And I've heard and I've seen many scenarios where a lot of people just turn their eyes, on us. We have to have my solution to this is always have an advocate for you when you're in a hospital or in these kind of situations. Always have somebody that you can trust that know what's going on with you, So when you're in there and you're complaining of something, they know this is not you. You don't have these kind of issues. You never had these issues before. They know you. My daughter is my advocate. She's everywhere I'm at. So she'll be the first to say, this is not my mother, She doesn't act like this. She's usually this way or whatever. But you have to have an advocate with you.
So that means, when you have your daughters pregnant and delivering, you need to be there as a mom. If you are alive, you need to be there to see what's going on with them, to speak for them, because you are their voice, because they're vulnerable.
Very vulnerable. Absolutely. They're medicated. They're in pain. They may be angry when they're sane. And a lot of times, as a healthcare professional myself, I've seen people get very, defensive. It's a patient. She's in an unfamiliar environment. This is where we work. It is normal for us to be here. It's not normal for her to be in this bed in pain. And we have to be a little bit more empathetic on our patients and understand that this is not normal for them. They could have 7 kids, but remember, they're not there 7 days or 7 months or 7 years in a row. It is maybe 4 or 5 years between children. And every pregnancy is different. So you cannot just judge and say, well, oh, she knows the rope. No, she doesn't. You know the rope, because this is what you do on a daily basis.
And a pregnant woman don't know what is normal. So you're delivering a baby and you think that what you're feeling is normal. Let me tell you, when I have my first daughter, I was about 20, 21, 22. And my water didn't break. I was there in pain, and the nurse came and she broke it. And then I was there waiting, feeling some pain, but I just didn't know what to expect, my first child. And then I noticed all the women deliver their baby. I was just there waiting. Nobody was coming in to check me. And I was there. There's no clock on the wall. I don't have it's not like I had a cell phone, then I could know the time. I didn't have a watch on. Some time passed. And then a sister in Jamaica, we call them sister, which is the head nurse. She came in and she said, "What are you doing in here?" And I said, "Having a baby." And she said, "Jesus Christ, one mother left in the room." I was left overnight in the delivery room by myself. Apparently the nurse forgot and she went home.
Oh my goodness.
Yes, I was there all night by myself.
And
she
you
came, the baby passed meconium. She started calling everybody. Everybody got panicked. The doctors came, like a whole group of people came. The baby was breech. Baby was in fetal distress, and they were trying to fix the breech manually. And they said, we have to do a C-section. And I did a emergency C-section. And I wasn't a medical person at the time. It was when I became a nurse, I realized everything that was going on. When my baby born, they were bagging her. Yes. You think that is normal, what your experience is normal, and there's nobody to check. You don't know how long this process should take. So this is how women can go into delivery room with a healthy, normal pregnancy, lose that baby, and also lose your life at delivery.
Oh, it goes back again to education. Education is key. And I feel like when women are pregnant, we all need to, do a little bit of extra searching and forget about the expensive. Not forget about the expensive baby shower, but there are more important things that you need to educate yourself on. What to expect in month 1, 2, 3, 4. There's so many information these days. Back then when we were having children, if it wasn't in a book printed somewhere where we probably would not have access to, we would not know what to expect. All you have to do is type on your phone. You don't even have to get a computer, and all the information is there. So I feel like it is important for women to educate themselves as to what to expect in each trimester of your pregnancy. Every pregnancy is different, but it also will tell you some things that are not normal, and you should check with your healthcare provider if you're experiencing these things. And I think education is the key to most of this. And I'm trying to educate my patients. When I see them, I ask them about how is the baby moving? Have you experienced any leaking of fluid, any vaginal bleeding, all of those stuff. You have to ask those questions every day. I had a patient just last week, and she had some spotting. She went to the hospital. They told her she was fine, did an ultrasound and sent her home. So she came to see me a couple of days later. She had no spotting at that time. It was about 4 days later. So I told her, I said, if this happens again, and we're not here, you need to go to the hospital and let them know. She came back on Monday and saw me again, which is a week later. And she said it happened 3 times. And I said, did you go to the hospital? She said, no, because the baby was moving. Now, the baby could be moving, but, there could be so many things happening at this moment. No, I had to send her to the hospital because at this point, we don't know why. The ultrasound did not show a placenta previa, which would be like the covering of the cervical canal that could cause bleeding. When I did my examination, there was not a polyp there that could also cause. She did not have sex. That could cause some vaginal bleeding. It wasn't heavy bleeding, but it was some spotting going on. So, to take caution, you send her to the hospital, let them do a full workup and make sure that there is nothing else going on. A placenta abruption, she probably wouldn't be bleeding like that on, depending on where it is and how far it is. But that is also something we need to look at, and she needs to be monitored because on an ultrasound, you would not see an abruption until it's about 50%. So it is important for us to educate our patient and say, these things aren't normal. We're not supposed to be experiencing these things.
So in terms of, placenta previa, placenta abruptia, sometimes you don't want to tell your patient too much because you don't want them to get scared. So you pretty much tell them, like for the spotting, if you see any bleeding, any pain that you never usually feel, because when you're pregnant in the last part, you're feeling some amount of pain. The pelvic girdle is loose and you're wobbling and you're just in a lot of pain. But, that's normal pain. What's abnormal pain?
You have to do that. You have to describe a kind of pain that you've never felt before. A pain make you feel like you can't breathe. So you have to get into, the descriptive part of it, so they can understand that this pain, it'll be different. You'll know.
Yeah.
Because in Belgrade, I have patients who have had 6 and 7 C-section. Sometimes
6 and 7.
Yes.
That means I can go back again then.
You
I have 3.
but that's recommended. The risks are too high for you. But yes, those are the kind of patients I see over there with that. So, I always counsel them about the kind of pain because they can easily have a ruptured uterus with that.
Exactly.
So you have to.
And you as a mother, you have to understand your body, speak up. A lot of time patients are afraid of their doctor, they don't want to come up against them, because when I was pregnant with my last one, I was just ready to deliver. And I wanted to go off and leave. And it's like, it's too early. That's another problem that a lot of women have. They want to go off early, but your workplace is not going to pay you for that FMLA. And you're waiting on the very last minute so you can get to spend a lot of time with your baby. But luckily for me, I was not full-time employed, so I could go whenever, but I just know that I'm not going to get paid. And when I told him I was ready to go off, he said, no, I can't. I said, listen, I'm not going back to work. So whether you give me the time off or not, I'm not going to go back. So when he saw that I was serious, he gave me my time off. He gave me my a folder with all my stuff and said, okay, if you're going into labor, turn up with this at the hospital. And believe me, I went home that weekend and I went into labor. I'm scheduled for a C-section and I went into labor. And I turned up at the hospital. I was very calm about it. I drove to the hospital, walked into emergency room and said, I'm having a baby. And they called my doctor. So when I reached inside now, he came in and he said, what are you doing here? I said, I told you last week that I was ready to have my baby. And when he checked, I had too much amniotic fluid. He's like, oh my God. He said, this is why you went into labor. He had to take some women off who he had scheduled for C-section and put me in because my baby was popping out and I had 2 C-section already. And when he cut, he said, your fascia is so thin. If you started having contraction, your uterus would have ruptured.
You had a window. That's what they call that, a uterine window. So yeah, your body knows. Your body knows.
Exactly. And you, the female, because you're feeling it. But sometimes they're going by the book and they're looking and say, okay, we can't give you time off. And let me tell you, when you're pregnant, sometimes you just gotta put away some money. I'm gonna say this, screw the job. You want to be alive. Sometimes you just gotta leave and just go home.
There'll always be another job.
Exactly.
I know it's easier said than done, but there'll always be another job. But if there's no life, there's no job. So you had to put that into perspective.
Exactly. And that's how you have to look at it. Like, okay, I'm not going back because this is how I feel. So As a nurse practitioner, you are in OB, I am in primary care, and sometimes I feel like I want to fix the world. When I see some patients in some situation, I just want to help, and you just want to educate, and then you realize that you can't fix it all, you can't do it all. As an OBGYN nurse practitioner, what would you do, or what would you tell the public to protect women who are pregnant to reduce maternal mortality rate?
Like I said before, education is the key. And the other thing is to always have someone there with you. Have someone who can advocate for you when you're in your most vulnerable state. You need to have someone there. And I'm not just talking about a husband, but someone, a sister or a mother, another female, another woman who understand what you're going through. I'm not up down on a man, but I that another probably more understand, you know, what's going on. So I think it's education is the key, and I think it's very important to, as much as you can during the period, what to expect and what's normal and what is not normal.
And prenatal care is important.
Very, absolutely, very, very important, because that's where we're gonna pick up on any problems before, it actually, or any issue before it becomes a major problem during your prenatal care. Getting your regular ultrasounds, doing your regular urine test, getting your blood pressure check every week, getting your sugar testing when it's due. And this is how we are going to know, what's going on with you. So we can protect you. It's not because we want money why we have you coming back every month and every 2 weeks and every week. It's because we want to take care of you and we want to take care of your health.
Okay. So you're going to be doing something in Jamaica in terms of, is it going to be maternal health or is it going to be OBGYN?
I'm just GYN, mostly GYN for now. I'm not sure where this is going to take us. I have a strong feeling it may take us over into the obstetrics as well, if I can find an OBGYN to work with us in Jamaica.
Yes.
But mostly it's going to be the GYN portion. I mean, I could do some OB there too, but I have to finish to get my credentials with the Medical Association in Jamaica to see what allow me to do there. But my main focus at the moment is women's health, because I think that there are too many women that are, honestly, if I know 10 women in Jamaica, they haven't had a pap smear. Some of them never in their life.
Never in their life. The first time I have a pap smear was after I delivered my first baby. I didn't know about pap smear.
Yeah, so I think education is important. What I would like to do is I would like to go into the colleges and even in high school and talk about these things. I want to talk about HPV vaccinations. I want to talk about, the protecting themselves from these things. And if you have it, and how you can screen for them, the importance of screening. Because when you go to a doctor and they say they go, a lot of times people think that they put a speculum in, they automatically think that you're getting a pap smear. I cannot tell you how many patients here in the United States that told me, I had a pap smear last week, or I had one in the emergency room. Emergency rooms do not do pap smears.
Exactly.
Swabs, they're checking for infection.
Yes.
They would never do a pap smear because that's not their role. So whenever there's a speculum goes in your vagina in the emergency room, it's never a pap smear.
Never a pap smear.
That done at your GYN or your primary care office.
Yes, so, and also a lot of primary care don't really want to do the pap smear, because sometimes you do a pap smear and it's not even done. It's nowhere near the cervix.
That's a story.
Well, guys, Nancy is my go-to person for OB.
Health clinic and get your pap smear done correctly, because it's not done correctly, then you're gonna miss if there's something there, and they may not call you back and say, hey, the pap smear result, we didn't get a result because it wasn't done correctly. Exactly. They may not even know. So you have to make sure you're going to the right people. It is so funny that I've heard people say to me, oh, I go to this doctor because of convenience, but then your A1C is 14, and yeah, it's been like that for the last 10 years. Excuse me?
They're
But
treating diabetes.
no, I'm not talking about the GYN. I'm just saying it's the same thing. You don't just go to any doctor for a pap smear
Exactly.
because if
Exactly.
they don't, you just gotta take, be more conscious. And I think the time that we're living in now, whatever disease or anything that we have, we need to know about our body. We need to educate ourselves about our bodies. We need to know what we need to do. We need to know what's screened. It is important to get these things done. Ask your doctor about pap smear. Ask your doctor, when is my next pap smear due? The insurance will pay for a pap smear every year. You
My
can get one.
insurance is writing me to tell me that I must do it every 3 years. And I said, nope, I'm doing it every year.
Most insurance will still pay for it. You do it every year. I don't see, because the thing what I tell my clients all the time, especially in the population that I serve, a lot of them not having the same partner for 3 years. They come this weekend, they do the pap smear, it was negative, normal. They go out, they find a different partner next week or next month, and they get HPV. They don't come back for 3 years. By the time they come back, we have a problem.
That's true.
We have a problem. So, you have to educate your patient and get them done. Do it. It needs to be done. I think
Exactly.
different criteria, and even when you have one partner, you still don't know, because you could have been exposed a while back and it just didn't show up until now.
Well, the problem that I had with doing the pap smear and doing the HPV, when I used to do it, I don't do it anymore. If the lady is below 21, they don't want to do the HPV screening. Do you find that they still have that guideline in place?
They do. If the woman is below 21, we don't do a pap at all.
But then they're having, just as you said, multiple partners might be exposed to HPV. But what I was told is that it takes like almost 10 years for the cervix for you to develop cervical cancer when you have HPV.
3 to 4 years before it can develop into cervical cancer. Now, what happened with younger people is that their immune system is a lot stronger. So sometimes the body takes care of that virus. And a lot of times it doesn't go further. But I had a 21-year-old who did her first pap smear. I had to do a colposcopy on her because she came back with abnormal cells, not just the HPV, but she also had abnormal cells.
You see, 21. So where do you draw the line?
Well, you got to follow that guideline for 21 as for now, unless, the patient has some kind of issue that they're complaining of, and you look at the cervix and you're like, I don't like the way the cervix looks, so let me do a pap smear on it.
Because even if you tick and say you want to do the HPV, they're not doing it at the lab.
They won't. And but you see, the thing is, because in a younger person, it does take a longer time to turn into cancer. So that's the reason why they don't run it at the lab. Now, what will happen is they can, and that's where you say the issue comes in, because 3 years down the line, you're going to pop up with ascus, which is a abnormal cells, or you're going to have dysplasia of the cervix, and you don't really want that to happen. But it's all insurance and politics. It's all how do you want to pay for things. And
exactly. Well, thank you so much, Nancy. Nancy is my go-to person. I used to work at a clinic. My first job as an NP, we didn't do women's health at all. We just do primary care. Then I got this job at a low-income clinic. And then first day they said, oh, in room 2 is your pap smear. And I said, what? When I was training as a nurse practitioner, yes, we did some pap smear for our women's health rotation, but I wasn't expecting to do any pap smear because I'm not working in women's health. So sometimes as a primary care provider, you have to know how to do a pap smear. And I was terrified. I had to call Nancy and say, Nancy, I have a pap smear. What should I do? It's the same thing that you do when you were in training. I said, no, walk me through it. And she walked me through that pap smear. And when I went into that room and I put in the speculum and then that cervix does pop, I said, yes. So you're an excellent teacher. And I know you do a little teaching as well in OB, is it RN student or nurse practitioner student?
RN students.
RN student. If you're in the Florida area, Nancy is a very wonderful OB nurse practitioner, and she will take excellent care of you. I know she has been trying to open a business in Florida as well. And now she has actually extended herself to offer the service in Jamaica, and I hope that will go well. I thank you so much, Nancy, for sharing your expertise and just having this chat regarding women's health, because it's something that we don't want to talk about, and women's health have so much to it. We haven't even gone into vaginal infection. That's going to be another topic, because a lot of women have this problem with chronic yeast infection, chronic bacterial vaginosis.
Absolutely.
Yes. And people just don't know how to treat it. I've been treating women for yeast infection, and like every time they have intercourse, they have a yeast infection or they have BV, I treat them with some medication, they're okay, and then it just keep coming back. And that's a whole different avenue that we need to talk about.
Because there are different testing that are being done now, because there are different kinds of bacteria that are causing the BV, which is still not sexually transmitted, but they weren't testing for those before. Now they're doing a lot more testing. And even with the yeast infection, there are different strain of the candida that causes the yeast infection. And some of them you're giving the fluconazole and it just won't go away. So exactly. Then you have to break down the strain of the yeast, the fungus, and then treat it accordingly. Because sometimes you have to be on it, not just one pill, but you may have to be on it for 7 days. Or even 14 days.
Exactly. So that's a whole nother topic that we need to talk about when I'm able to catch you again. I've been trying to get this interview since last year, and every time I schedule, I see her in Dubai, then I see her in Ghana, then I saw her in Jamaica. Like, what's going on with Nancy? Like, Nancy is so busy, but I'm happy that you are working, enjoying your life as well.
I am very busy, but one important thing that we all have to remember, that we only get one life. So we have to find time to take care of ourselves. And I use those time as my self-care time, you know.
Exactly.
I travel, and then after I'm done, I get refreshed and I'm ready to take on the world again, you know. So have to take care of ourselves. We don't get do it over again. I'm going to be 47 soon, and I don't get to be 45 again. So, you know, we have to spend time. We have to make sure. You cannot make a job take away all your time, because you really, after a while, that it's going to become a job and something you don't want to do. When I go away and I come back, I go back to work. I don't even feel like I'm going to work. I'm just doing something that's a part of my schedule, and I'm doing what I love to do.
Okay. So Nancy, when you launch your thing, just I'm gonna try to have you back so you can put your information out. And if you ever do open your clinic in Florida, this is a good way to put your information out as well.
I sure will, my dear. Thank you so much for having me.
Thank you, Nancy. This is Dr. Morgan, and this was Health Talk. Have a good day.
Bye-bye.